Dear colleagues, I'm very happy to be here. It's an honor for me to be here and speak with you, look at you, not in online regime, but offline regime. It's very important for us because in Zaporozhye now we study our students and residents, not residents, well, no, only students online. It's terrible. I want to show you, we will speak about regional techniques of analgesia. It's not a war problem, so war is continue, but life is continue too. We have a good, I think we have a good team, cardiac surgical team in Zaporozhye now. And we'll speak about some regional techniques which we will use during this surgery. But at first I want to say, I know some words in Moldovan. Bună dimineața. Da. But, dragi prieteni, felicitări pentru 50-a aniversare. Dezvoltați-vă, imnunați-vă și de mâini și bucurați-vă de muncea voastră. Thank you very much. So I don't have conflict of interest. It's a picture from Paolo Pilosi. You know him. Unfortunately, he was dying 2 years ago, and I always, before he was dying, I asked him, Paolo, can I show this picture for audience? No problem, please show. And it's a history of our medicine, I think. Today I heard the lecture from Professor Yuri Akalovsky. You have a good history of your Moldavian society. Good. I look now at Professor Adrian Belli, but I think it's at the beginning of 20th centuries you were as a trainee, like a trainee, yeah? It's very important. Please remember your teachers. I said it especially for young generation. Remember it. Okay, let's go. Some slides about history in cardiac anesthesiology. Look, it's a book from Edward Lowenstein, and look at this slide. High doses opioid anesthesia, high dose fentanyl applied. So when I start my work, I have a history about a little bit more than 30 years in anesthesiology, and I remember the protocol of cardiac anesthesia when we used 60, maybe 80, maybe 100 ampoules of fentanyl. Maybe you remember the same information. But today we spoke with artificial intelligence. So I give these questions for artificial intelligence and have some answer. Cardiac anesthesia has evolved from standardized high opioid techniques to personalized patient-centered approach and focus on enhanced recovery after the cardiac surgery protocol. Yeah, modern cardiac anesthesia emphasizes optimizing patient care, reducing complications, etc., etc. So the modern step in cardiac surgery, it's ERAS, enhanced recovery after surgery protocol. And what we have? It's guidelines from experts published in JAMA 2019. And look, recommendation. Okay, we can use a perioperative multimodal opioid-sparing pain management plan for all of these patients, but In these guidelines, we have information only about acetaminophen, tramadol, dexmedetomidine, and pregabalin or gabapentin. No information about regional anesthesia, unfortunately. And of course, the second point for the cardiac surgery is strategies to ensure extubation within 6 hours after surgery. It's very important, of course. What we can do for this, what can we use for this? Time-directed extubation protocols and low-dose opioid anesthesia. Low dose, not 60 ampoules or 100 ampoules during cardiac surgery. Low. Why? Sorry, not why. How to do this without opioids? Of course, multimodal anesthesia. And I find some information for you from 2024. It's experts' statements. Yeah, good information. And look, structured strategies to facilitate extubation within 6 hours. Okay, and the level of evidence moderate. It's not bad. Highly selective intraoperative and intermediate postoperative extubation may be appropriate for patients that are going to low risk. Okay, but the level of evidence low, unfortunately. And the next two. A multimodal approach, reduced reliance on opioid-based analgesia, and optimized perioperative pain management, moderate, and I think main topic. Chest wall regional analgesia can be an effective component of multimodal approach to perioperative pain management. Yeah, very interesting. So, chest wall, we need to block. How? There are many blocks. So, when I started my work in anesthesiology, it was 1992. So, we have for thoracic analgesia epidural. Only epidural, thoracic epidural analgesia. Only, because we don't have an ultrasound in our hands. Now we have it. I don't know exactly, but I hope all anesthesiology department in Moldova have this probe, ultrasound probes. Yeah or not? Not? Wow. In Ukraine we have, of course it's a help from European society, from another countries, yeah, but now in all anesthesiology department in Ukraine we have probes, not only linear but convex probe, we have it. And can do this so-called intra-fast cell blocks. It's very simple technique, very simple. If you can look at this picture and see the intrafast cell space, you need to use anesthetic in this space and block some nerves, some plexus, doesn't matter. So, which block we can use? So, TIA, yes. And TIA, it's without ultrasound, of course, but another blocks. ESP block, erector spine block, paravertebral, pleural, maybe. I didn't use it. But serratus anterior, and other blocks. We can use these blocks for thoracic wall blockade. Which block we can use during cardiac surgery? So it depends of the risk versus benefits equation. Yeah. In the beginning of 20th century, in Zaporozhye, where we work, we start to use epidural analgesia for cardiac surgery. But, okay, it's a meta-analysis from 2023 years. So, look, 51 randomized controlled trials and clinical benefits. Of course, reduce ICU, length stay, hospital length of stay, what else? Extubation, trachea, reduced pain score, etc., etc., etc. But risk, epidural hematoma. Risk is very low, 0.14, almost nothing. But it's a risk. Maybe you have a patient with epidural hematoma. No? God with you. If you have this patient, it's a problem. It's a very big problem. And what interesting in this, from this review? No significant change in mortality, unfortunately. That's why now ASRA guidelines shows us the risk of hematoma from this to from 1 to 1,500 to 1,300 during spinal anesthesia. Very interesting. Today I spoke with Vyacheslav Savan. You know him, yeah? He works now in cardiac anesthesiology in France. And what they use the morphine, intrathecal morphine, for cardiosurgery. We don't use in Ukraine because we don't have this morphine. Yeah, they have, and they said very interesting, with very good results. But from ASRA guidelines, look, we need all the time, if you want to use a neuroaxial blocks, we need all the time think about risk of hematoma. So how to prevent it? Yeah, neuroaxial block should be avoided in patients with coagulopathy. As for me, the contraindication number 2. So we don't know if we use this needle and have a hemorrhage, some hemorrhage. So we will say to our surgeon, stop. 24 hours later, you will operate the patient. Never. Yeah. So risk and benefits. That's why now TIA not used for ERAS protocol in cardiosurgery. No. What about blocks? When I prepare my lecture, I find the perfect, beautiful, I don't know, in other words, paper from our Italian colleagues. So it's a paper in Journal Clinical Medicine 2025. It's free access for this paper. You can use it in your work. You can read it. And very interesting information about regional blocks, which we can use during cardiac surgery. So they start from the sternum. Yeah. So pector intercostal plane block indications: median sternotomy, mammary region pain after harvesting, and other indication. The next. So anatomical targets and how many local anesthetic you need to use for this block, and tips and tricks for successful block. Very good article. If you will have interest for this, please read it. And of course, look, now we have, I repeat, we have ultrasound in our hands. So use interfascial block. It's very, very simple. The next block, IPP, so intercostal plane block, postoperative sternal analgesia, placement of anterior chest drain, and others. Anatomy and how many milliliters of local anesthetic, and tip and tricks. Yeah, and look at this picture. Patient is laying after intubation, maybe before intubation, but the cardiac patient must be intubated. And after this, we need to use some blocks. Yeah, it's very simple. The next, PSP, pectoserratus plane block. So no indication for surgery, but pain management after thoracotomy. thoracotomy is association with serratus anterior plain block. It can be used for in our practice. Look, it's very simple. Next one, sub, serratus anterior plain block, the same situation, the same information. Maybe now we use these blocks for our soldiers who have a drainage after thoracotomy, after some surgery on the thorax. Perfect, working good, especially for transportation. So you don't need to use morphine or another opioids. Use block and patient can breathe well. And ESP block, erector spina or spine plain block. Perfect block. It's a block for anesthesiologists. Maybe some of you did it in your practice. It's good and safe block. Safe, very safe block. And which block is better? So the the article from British Medical Anesthesiology, effect of ultrasound-guided regional anesthesia and cardiac surgery, a systematic review and network meta-analysis. Look, they compared some blocks, so it's placebo, ESP, PEX, PIF, TTM, very interesting. The Professor Alex Yoskevich said about protocols for different clinics. Very interesting. In different clinics, the same blocks for same blocks, they can use different abbreviation. So, okay, blocks work. And how? Morphine milligram equivalence, ESP is the best. Pain, non-significant. Time to compare to placebo. Time to extubation, non-significant. ICU loss, ESP works, another not. Hospital loss, non-significant. PONV, non-significant. And what interesting for future generation, for young, the quality of evidence. Low, very low. Not enough evidence for these techniques during cardiac surgery. Why I said about it, I will say later. Systemic review meta-analysis ESP blocks. Look, single shot block, ESP block, different information, but pain scores decrease, cumulative postoperative decreased, pain score at postoperative hour after 12 hours, not significant length of hospital stay, not significant. Yeah, so it's information, we say this information for what? We need to have another additional studies about this. Maybe in Moldova, why not? And PIP, parasternal intercostal plane block. So meta-analysis, we have meta-analysis, only one. Another blocks, serratus anterior blocks, and another blocks, we don't have, unfortunately, we don't have a review, we don't have randomized controlled trials. But again from Italy, look, recommendation for fast-track extubation in dull cardiac surgery patient, consensus statement. And the first two places, parasternal block, erector spine, plain block. Local regional anesthesia using these blocks work. And I find only one ERAS protocol using for cardiac surgery, using regional blocks. It's from Lausanne, from Switzerland. Look this protocol and local infiltration or parasternal intercostal plain block. And what interesting, I asked Vyacheslav Savan, what do you think about it? He answered, it's very simple, because the surgeons do these blocks, not anesthesiologist. So we need to say our surgeons, please do this. Okay, so good information, less morphine and other positive effects. It's our work. From Zaporozhye, we have Ukrainian Journal of Cardiovascular Surgery. We use this block, bilateral extended ESP block in cardiac surgery. We use the prolonged block, so use a catheterization of these spaces. And what we have, it's our protocol. Sorry, it's a Ukrainian language, but I think it doesn't matter. Intraoperative analgesia, we use fentanyl only. During surgery, only 2-3 microgram per kilogram during all time of surgery. I have 100 kilo, at least a little bit more. So 3 ampoules only. No, it's not a problem, absolutely. And lidocaine intravenous and ESP block using ropivacaine. During surgery, we use 0.75% of lidocaine for each catheter, about 15 ml. And after surgery, use ropivacaine 0.2, 0.5, the same 10, 15 ml for each side. And which result we have? Time of extubation. I never see it before. So 20 minutes. 20 minutes after cardiac surgery during 6 hours. Mobilized, activity of mobilization of patient. Yeah, 5 hours. After 5 hours, they can sit in the bed, not running, of course, not jumping, but sitting. Yeah. Use opioids. Look, only 4 patients from group from 66 patients only use opioids as a rescue analgesia. Yeah. And time in ICU, 65 hours. Yeah. I don't know. I think it's a good result. And why we need to use opioids if the visual analog scale for these patients, red line, only 2 maximum. This is our work. Maybe you will use this, our work in your practice too. One slide about chronic pain, chronic post-sternotomy pain. So we have these patients. Today, the Adrian Belli said about depression and anxiety and after the pain after surgery. So we can I don't know how to say, перевернуть, изменить. Switch this, yeah. So the pain post-operative, post-sternotomy pain, and depression and anxiety and chronic pain post-sternotomy. The percentage is about 30%, 1 year after sternotomy. But we don't have studies about it. No studies, only case reports from Malaysia, for example. Only for treatment we can use the regional blocks in these cases. That's why, in conclusion, regional anesthesia technique are important component of Iraq's. Yeah. Thoracic fast cell blocks compared to TIA are the safest technique. Doesn't matter which technique you will use, it's safe. And very important, more research is needed to confirm the effectiveness of these blocks. That's why I want to ask you to do this, and maybe 10 years later you will be like a Professor Adrian Belli. Yeah? Thank you all for this friendship.